Bismillahirrahmanirrahim. This video will describe the fracture and healing. The references for this video are these. By the end of this video, the 4th year MBBS student should be able to describe fracture, discuss the pathogenesis and morphology of the fracture, what are the associated complications, and what are reactive bone formation, heterotopic ossification, calcification, and myositis ossificans. So fracture can be defined as a loss of bone integrity or loss of bone continuity. There are many types of these fractures. Some are termed as simple fracture when the overlying skin is intact. Some are compound in which bone communicate with the skin surface. If the bone is fragmented, then it is termed as comminuted fracture. If the ends of the bone are not approximated or aligned and are displaced, so this is termed as displaced fracture. When on a bone there is repetitive load and it follows a period of increased physical activity, this is termed as stress fracture. If the bone is incompletely broken and the discontinuity or loss of continuity is only extending partially through the bone thickness, it is termed as green stick fracture, and it is more common in infants. When there is some underlying pathological process going on and which results in fracture, that is termed as pathologic fracture. When a force is applied to the perpendicular to the long axis of the bone, it will result in transverse fracture. When the force is applied in the long axis of the bone, it will result in compression fracture. When the torsional force is applied, it will result in a spiral fracture, and the combination of various forces will result in displacement of the fractured fragment of the bone. The fracture is associated with other injuries also, such as the surrounding muscle or soft tissue or blood vessels, tendons, ligaments which are attached over there, and the nerves. Healing is divided into various phases. These phases are inflammatory phase, reparative phase, and remodeling phase. And the duration of each of these phases depend on some local and systemic factors. The systemic factors which are responsible for fracture healing are patient age, overall health status of the patient, nutritional status, and these factors alter activity and proliferation of the bone forming cell, which alters the callus formation. Cigarette smoking also affects fracture healing, as nicotine causes vasoconstriction and diminishes blood flow at the fracture site. The diabetes mellitus is also associated with collagen defects such as decreased collagen content, defective cross-linking, and alteration in the collagen subtype ratio. Use of anti-inflammatory drugs, though temporarily, it also reduces the bone healing. The local effects are extent of associated soft tissue injury, interruption of local blood supply, interposition of the soft tissue at fracture site, and bone death caused by radiation, thermal or chemical burns, or if there is a focus of infection which is present in that environment. In inflammatory phase of the fracture healing, during day 1 and 2, there is extensive hemorrhage as a result of rupture of vessels of periosteum, muscle, and surrounding soft tissue, and this extensive hemorrhage and along with destruction of the large vessel and subsequent interruption of the blood supply to the bone results in extensive bone necrosis. This bone or necrosis or dead bone is characterized by absence of osteocytes and empty osteocyte lacunae. During day 2 to 5, this hemorrhage develops further and it becomes a large clot, and this large clot become new vascularized or develop new blood vessels, and this new vascularization starts from periphery of to this large blood clot. By the end of week 1, there is clot organization, which is characterized by new vascularization, we just discussed, and early fibrosis. There is formation of woven bone also. This woven bone spicules, they begin to appear in the periphery of the clot and also inside the marrow cavity, along the margin of this blood clot. These are bony spicules, woven bony spicules, they develop due to differentiation of pluripotent mesenchymal cells into osteoblast, and in some cases there is formation of cartilage also. This cartilage is, however, resolved by endochondral ossification. So what is callus? Callus is the granulation tissue containing bone or cartilage. So this picture is describing the changes we just discussed. On your left you can see that there is a presence of a large blood clot in the fracture site, and there is presence of cortical dead bone which is characterized by empty lacunae over there. Within days there is presence or appearance of the fibroblast, deposition of the collagen, and appearance of these small blood vessels, new vascularization, which start from the edge of this blood clot and also on the inner side or inner margin of the blood clot also. The second phase, which is the reparative phase, it lasts from weeks to months, and it depends on the degree of movement and the fixation of the fracture. In this phase, there is dissipation of the acute inflammation. The pluripotent cells, they differentiate into fibroblast and osteoblast, and there is repair from periphery to the center. The objective for this reparative phase are to organize and resolve the blood clot and revascularize construction of the callus, which is going to bridge the fracture site. In reparative phase, the osteoclasts form cutting cones that move into the cortex to fracture site, and these cutting cones have a new vessel also, which is responsible for supply of nutrients and pluripotent cells to this environment. At the same time, the external callus formed from the periosteum and differentiation of the mesenchymal cells continue to grow toward the fracture site. So does the endosteal callus. They reach to the fracture site, and the end of the fracture fragment start to appear smooth. When there is a cartilage area, the new blood vessel invade the calcified cartilage, after which there is duplication of the endochondral sequence of normal bone formation at growth plate. The reparative phase is responsible for collection of all constituents needed for remodeling to start. Here you can see that jagged edges of the cortical bone have been eroded. There is revascularization of the marrow spaces, and the callus is composed of cartilage and woven bone. So the remodeling phase begins once the callus has sealed the bone ends. The bone is reorganized and restored in this phase. The process of remodeling continues beyond the period of clinical healing. This may continue for years, as happens in rib fracture, where callus persists for lifetime due to continuous respiratory movement which disturb and shear small blood vessels and preserve cartilage callus. If there is a fracture in a child before the closure of growth plate, the fracture is not recognizable in later life, as the normal process of modeling overtakes the callus. This also corrects the angulation, if any, present at the site of the fracture, which requires correction in adults through internal or external devices. So the Wolf law states that the bone is restructured in response to stress and strain. In remodeling phase, the new bone, which may be woven or laminar, is organized along the stress line and mechanical forces and the activity of osteoclast and osteoblast, which work with as a basic multicellular unit, is maintained. This photomyograph is showing the histological appearance of a callus. There is presence of osteoblast, osteoid, new bone is formed along with granulation tissue. So all these are the components of a callus. So the healing of the fracture is regulated by many genes, as numerous cytokines and growth factors encoded by these genes, and these are required for the normal healing. In the upcoming section, we will learn the various action of these factors. The initially made clot form a fibrin meshwork which act as a scaffold for inflammatory cells, fibroblasts and capillaries. Inflammatory cell and platelet liberate platelet-derived growth factor, transforming growth factor beta and fibroblast growth factor. These in turn activate osteoprogenitor cells which enhance the activity of osteoblast and osteoclast. Initially a procallus is formed, which is devoid of any calcified tissue. The procallus, which is calcified, is transformed into a callus, and the callus achieves maximal girth around 2 to 3 weeks. So this fracture environment is enriched by various growth factors, cytokines, prostaglandins, leukotrienes, hormones and vascular factors. The various growth factors are transforming growth factor, bone morphogenetic protein or BMPs, fibroblast growth factor, platelet derived growth factor, insulin like growth factor, while the cytokines are interleukin 1, 4, 6, 11, macrophage granulocyte colony stimulating factor and tumor necrosis factor. The prostaglandin and leukotrienes are also responsible for the healing. Then there are numerous hormones which we will discuss later. The vascular factors are vascular endothelial growth factor and angiopoietin 1 and 2. The role of the growth factors now. The transforming growth factor is a superfamily of growth factors, comprises about 34 members. It acts on serine threonine kinase cell wall receptors, promote proliferation and differentiation of mesenchymal precursors for osteoblast, osteoclast and chondrocyte. It stimulates both endochondral and intramembranous bone formation, and as it induces synthesis of cartilage specific proteoglycans and type 2 collagen, it also stimulates collagen synthesis by osteoblast. So So the bone morphogenetic protein is another growth factor, which is osteoinducive protein, initially isolated from the demineralized bone matrix. It induces cell differentiation, promote N-chondral ossification, and regulate extracellular matrix production. The osteoinducive character is proven by the bone formation in heterotopic muscle pouch. BMP3, which is also termed as osteogenin, is a potent inducer of mesenchymal tissue differentiation into bone. The BMP2 and BMP7 induce endochondral bone formation, and BMP1 is the enzyme that cleave the carboxy terminal of procollagen 1, 2 and 3, hence regulate the extracellular matrix production. These bone morphogenetic proteins are the member of the transforming growth factor family, except BMP1. There are about 16 bone morphogenetic protein identified. BMP2, 7, 9 are osteoinducive, while the function of 2, 6 and 9 is osteoblastic differentiation. They work through the intracellular SMAD pathway, and the concentration of the bone morphogenetic protein is directly proportional to the response. The noggin and BMP13 are considered as BMP antagonist. The noggin is an extracellular inhibitor and competes with BMP24 receptor binding, and BMP13 is found to limit the differentiation of mesenchymal cells, hence inhibit osteogenic differentiation. The fibroblast growth factors, both the acidic and basic forms, are considered as a growth factor for bone healing. They increase proliferation of chondrocyte and osteoblast, enhance callus formation, and FGF2 stimulates angiogenesis also. The platelet-derived growth factor is a dimer of products of two genes, platelet-derived growth factor A and B. The PDGF-BB and PDGF-AB are the predominant forms formed in the circulation. They stimulate bone cell growth and act as mitogen for cells of mesenchymal origin. They increase type 1 collagen synthesis by increasing the number of osteoblasts, while PDGF-BB stimulates bone resorption by increasing the number of osteoclasts. So this is a table from the biology of bone repair, which is showing that there are a lot of these growth factors which have got a specific time and function for this bone healing. The insulin-like growth factor is another growth factor which has got two types, 1 and 2. They are synthesized by multiple tissues. The type 1 is stimulated by growth hormone in the liver. It stimulates bone collagen and matrix synthesis and also stimulate the replication of the osteoblast. However, they inhibit bone collagen degradation. So interleukin 1, 4, 6, 11, macrophage and granulocyte macrophage, colony stimulating factor, and tumor necrosis factor are the cytokines which are involved in the regulation of bone healing. The interleukin 1 is the most potent one, and it stimulates bone resorption. Interleukin 1 and 6 synthesis is decreased by estrogen, and this peak for this cytokine is during first 24 hours, then it again increases during remodeling. It also regulates enchondral bone formation. A cornucopia of cytokines is involved in the regulation of bone healing. The interleukin 1, TNF alpha and TNF beta have got weak bone formation action, while they have got a strong bone resorption capability. While the TGF beta and PDGF both have got equivalent bone formation and bone resorption function, while insulin-like growth factor 1 and 2 and fibroblast growth factor have a strong activity for the bone formation, while they have got no activity for the bone resorption. The prostaglandins of the E series, they stimulate osteoblastic bone function and inhibit activity of the isolated osteoclast, while leukotriene stimulate osteoblastic bone formation and enhance the capacity of isolated osteoclasts to form resorption pits. There are number of hormones which are responsible for the regulation of bone healing. One is the estrogen, which stimulates fracture healing through receptor mediated mechanism. For a detailed mechanism of action of the estrogen on bone, please refer to the earlier video on osteoporosis, in which this mechanism is described in detail. Then the thyroid hormone is both the T3 and T4 stimulate osteoclastic bone resorption. The glucocorticoids inhibit calcium absorption from the gut and causing increased parathyroid hormone and therefore increased osteoclastic bone resorption. The parathyroid hormone, the intermittent exposure to the parathyroid hormone stimulates osteoblast and increased bone formation. The growth hormone activity is mediated through insulin-like growth factor 1, which is also termed as somatomedin C. It increases callus formation and fracture strength. The vascular factors which are involved in regulation of bone healing are metalloproteinases and angiogenic factors. The metalloproteinases degrade cartilage and bone to allow invasion of the vessel, while angiogenic factors are vascular endothelial growth factors that mediate the neoangiogenesis and endothelial cell specific mitogens, and angiopoietin 1 and 2 both regulate formation of larger vessels and branches. The bone healing can be divided into primary or direct and secondary or indirect healing. The primary bone healing is seen in the settings when there is no motion at the site of fracture and it does not involve formation of fracture callus. The osteoblast in this process originate from endothelial or perivascular cells. A cutting cone is formed that crosses the site of fracture. Osteoblast lay down lamellar bone behind the osteoclasts and forming a secondary osteon. Gradually there is formation of osteon and more osteons and fracture heals. It is a slow process and takes months to years. Examples are drill hole or osteotomy, when a fragment is removed by a fine saw during orthopedic surgery and the soft tissue response is very low or not present at all. Bone is also fixed rigidly, which stops callus formation. The fracture callus grows only at the fracture site. There are two components of this direct healing. Number one is the contact healing and another is the gap healing. When they are direct in contact, both the fracture surfaces are direct in contact with each other, there is direct deposition of the lamellar bone, hence healing occurs. While in gap healing, if the gaps are less than 200 to 500 microns, these are primarily filled with woven bone that are subsequently remodeled into lamellar bone. If the gaps are larger, then there is partial filling by the fibrous tissue which undergoes secondary ossification. The indirect bone healing is as the name implies, this indirect bone healing or secondary bone healings occurs when there is deposition of procallus or callus which then ossifies and responsible for healing of the fracture, and we have discussed this process in detail already. Now the complication of the fracture healing, one is the fibrous union in which there is failure of the osseous union, there is there is lack of immobilization of the fractured bone, and it will result in appearance of the synovial membrane or synovial-like membrane at the fracture site, which result in pseudoarthrosis. Another is the non-union. A fracture that has not healed and shown no potential to heal without further intervention is termed as non-union. And if a fracture site that fails to demonstrate clinical or radiological improvement over 3 months, it is labeled as non-union. It may result if some soft tissue is interposed between the fracture end, and they can be labeled as atrophic, hypertrophic, or infected varieties. Delayed union occur when there is delayed wound healing as such as due to infection, inadequate blood supply, poor nutrition, movement, and old age. Stress fracture, also termed as march fracture or fatigue fracture, are due to repeated microfracture eventually result in true fracture through the bone cortex. There are some bones in the body which have got few osteons, and when stress applied to the cortex, such as in fifth metatarsal bone, these ill-prepared cortex undergo repeated mechanical stress. As a result, the bone compensates to produce cutting cones to implant more osteons. If the stress continue or microfracture accumulate, there are more periosteal and endosteal calluses formation to strengthen the bone and remodel. But if the stress is continually applied during remodeling, actual fracture occurs. The clinical picture is pain and swelling over the affected bone, and a callus forms before the fracture occurs at the site of fracture site. And when the actual fracture takes place, the pain becomes more severe. It is difficult to distinguish this stress fracture from the tumor because even on histology, the cortex is filled with cutting cones for remodeling, and these cutting cones are also numerously seen in reactive bone at the edge of an invasive tumor. Now the reactive bone formation. Reactive bone formation is the intramembranous bone formed in response to a stress on bone or soft tissue. It is derived from the periosteum or endosteal tissue of the marrow. The conditions in which this is formed are tumors, infection, trauma, or generalized or focal diseases. The periosteum may respond with a sunburst pattern, or due to progressive deposition or layering of the periosteum, it may result as onion skin appearance of the cortex. Radiologically, the cortex is thick and dense, and the cancellous bone is coarse. Both the woven or lamellar bone can be seen. It depends on the rate of deposition of the new bone. The lamellar bone is commonly seen in chronic osteomyelitis and benign tumor. In this situation, the periosteum has sufficient time to respond to the stimulus, while in rapidly enlarging tumor, woven bone is usually seen. This is the lower end of the femur, which is showing the reactive bone formation, showing sunburst pattern, and the growth is involving the soft tissue also, so the bony architecture is also obscured. The epiphyseal plate is delineated by radiolucent transverse area. When the bone is formed outside the skeletal system, it is termed as heterotopic ossification. Both the woven and lamellar bone can be formed, and the sites are skin, subcutaneous tissue, skeletal muscle, and fibroconnective tissue surrounding the joint. It is not associated with any metabolic disease, and the serum calcium and serum phosphate levels are within normal range. It is seen in certain clinical settings, such as in genetic, the fibrodysplasia ossificans progressiva. It is a disease in which there is massive deposits of bone around the multiple joint is seen. It is also common post-traumatically when the bone deposition or bone formation is seen in hematomas and skeletal muscle. The muscle and periarticular fibrous tissue at multiple sites in patient with head trauma, spinal cord injury, or prolonged coma are also seen producing heterotopic ossification. It is also common in post-surgical cases in which there is periarticular soft tissue bone deposition following joint surgery. And there is another distinct variety of this heterotopic ossification which we'll discuss in detail later, and that is the Myositis Ossificans. The heterotopic calcification is a term which is used to describe the deposition of calcium salt in the soft tissue. Radiologically, this is distinct from heterotopic ossification, as this heterotopic calcification is irregular, splotchy, and amorphous in appearance on radiology, while the heterotopic ossification appears spicular or trabeculated in appearance. The heterotopic calcification tend to occur in necrotic soft tissue or cartilage, and these are denser than the bone. It occurs by two patterns. One is the metastatic calcification, another is dystrophic calcification. The metastatic calcification occurs in hypercalcemic state and hyperphosphatemic condition when there is increased calcium phosphate product. The dystrophic calcification is seen in abnormal or damaged soft tissue such as tumor, degenerative disease such as arteriosclerosis, and areas subjected to the trauma. The loss of neurological function such as quadriplegia and hemiplegia predispose the affected part of the soft tissue calcification. A distinctive form of heterotopic ossification is Myositis Ossificans, which is formation of reactive bone in the muscle after injury. It usually affects younger individuals, remain benign and self-limited, and have excellent prognosis. No treatment is required for this disease. Then the Myositis ossificans can be result of blunt trauma to the muscle and soft tissue, and it can develop spontaneously in the soft tissue or muscle. What are the events? If there is a damage to the tissue, it will result in hemorrhage, and subsequently there will be development of new vascularization, which is more prominent in the periphery, and subsequent fibrosis, and finally bone spicule is formed inside. On microscopy, it is evident that this woven bone is formed within granulation tissue and reactive fibrous tissue. The center of the lesion is filled with proliferating fibroblast, while the periphery shows osteoblast population to form woven bone. Atypia and abundant mitosis are present in the fibroblast. which mimic a malignant tumor. But this condition is distinguished from malignancy by zonation effect. In myositis ossificans, the bone matures peripherally, but the center is immature or not formed. The zonation effect is opposite in malignancy, when there is more dense bone formation in the center. In the later stage of the disease, as this woven bone is replaced by the lamellar bone, it may mimic a sesamoid bone. On the left, the MRI is showing axial view of the thigh with a femur and adjacent ovoid intramuscular mass. On the right side, the low power view shows peripheral woven bone and central fibrosis. So this is the mind map for this video. In the start of this video, we discussed the definition of the fracture, type of the fracture and patterns according to the force applied. Then the various factors which affect healing process, what are the phases of healing, and the local regulation of the healing. We have seen that there are many local growth factors, cytokines, hormones, and other factors are responsible for the healing. Then what is primary healing and what do you mean by secondary healing? Then we have seen the complications of the fracture such as non-union, etc. We discuss what is a stress fracture, and then detailed account of the reactive bone formation with the differentiation between the heterotopic ossification and heterotopic calcification, and with a special emphasis on the myositis ossificans.